And we are live. Hello and welcome to our first Instagram. Now, I've already told you I'm going to massacre your name, but I'm going to give it a go just because I can. So, all right, so Dr. Itunu Johnson Showbiton. Close?
Yes, close enough.
I feel you might pause as it
Not
goes.
bad. To be honest, I think even Nigerians struggle. So don't worry. Don't worry at all.
Far easier just to say Dr. Show cares, Dr. Show. That's much easier.
Yeah, you
Yeah.
can say that. That's fine.
Oh, it's so sad when you're linguistically challenged. Now, you are a GP, you have a special interest in women's health and menopause, and you're also doing some really, really important stuff when it comes to diversity in the communities and the Black community, because, I mean, as we know, you don't get it. You don't get the good stuff right from the very start, and it just
Unfortunately, Black women get the short end of the stick in many, many aspects.
Yes, exactly. So we are going to get rid of that thing. We are going to run through sort of what's going on, but also, you know, on the positive side of it, working out what you can actually do to turn these things around
Right.
to help yourself. And you've actually made a really nice little booklet as well, which is great for people to really understand what it is they're going through and why these different things affect Black women more in some ways, because it's almost like a perfect storm when it comes together. You've got a lot of things going on, and then you get menopause that throws in a whole lot of other stuff, especially those vasomotor symptoms on top. So let's have a little run through of some of the things that it does do when you're looking at the SWAN study was an interesting one. It looked at midlife Black women and looked at 6 areas where they were much worse off. The vasomotor symptoms, depression, sleep, metabolic risks, so your cardiovascular disease, heart attacks, and your diabetes, physical function, and then quality of life. And these are all sort of quite important things. So what is it that happens to Black menopausal women when they hit perimenopause?
So it's really interesting because Black women hit perimenopause younger than white women. And that's one of the things that the SWAN study did. Now, we have to remember that the SWAN study was looking primarily at African American women. And we'll talk about how this might be slightly different for Black women in other parts of the world. But it's really the best indicator of data that we have because it was a reasonable number of women that was studied in this cohort. Now, when it comes to vasomotor symptoms, so for those who don't know what that is, that's the hot flushes and the night sweats, which around 80% of menopausal women will have. But remember, some do not. But in Black women, what the study did show was that they were more severe, more frequent, and they lasted longer. And this has an impact on so many things because we know that vasomotor symptoms because there are complications from the menopause. Of course, menopause is a natural process. No one's calling it a disease process, but there are things that women experience in their health in the future following menopause. And one of this is heart disease. And we know that there's a strong association with stronger, more intense and longer lasting vasomotor symptoms and heart disease. And of course, Black women are in this perfect storm, as you described.
Yeah, because the European, I'm probably going to get their name wrong, but one of the large bodies for cardiovascular disease in Europe has actually called for vasomotor symptoms to be classed as an independent risk factor for heart disease in women in menopause. So it's an interesting thing, and especially the other side of this is, of course, that you have them, as you said, starting younger, more severely, and for longer, but you're 50% less likely to get treatment for it.
And this is what I'm really passionate about because I know we're going to talk about this in a lot more detail. Shockingly, Black women know less about the risks. They know less about the treatment options, and they are engaging less with the treatment options. And there's a lot of fear. There's a lot of myth. There's a lot of cultural hesitation. I mean, understandably so. And we'll talk about some of this because of real things that have happened that have meant that there's reduced trust in the medical establishment for lots of Black women. And, you know, health inequity in the Black community is wide ranging. And this is just one of those issues where it's also affected.
Yeah, absolutely. The that getting to certain aspects of certain communities is very, very hard, and especially if you don't have that trust. But you also mentioned there's a cultural and sort of social issues in there, and myths and things. How what sort of things are going on there that make it different for a Black woman?
So, I mean, again, being Black is not a monolith. Yes, there are threads that connect in terms of Blackness. I always joke that I didn't become Black until I moved to the UK at the age of 15. Prior to that, I was a Yoruba Nigerian girl, right? So now, we have Caribbean people from all different islands. We have African people from all different countries in Africa. Then we also have British born Caribbean or African people. We have first generation, we have second generation, and we're now even getting third generations coming through. And so these are all have different little cultural differences. They're very varied. It's not a monolith, but there are threads, right? And one of the threads is distrust. And part of that is linked to historical discrimination and racism. And I think it's really important to name a thing,
Yep.
right? It's important to name a thing. I know it can make people feel a bit uncomfortable, but there is history there. There is a weight of history. That means that Black people have had the short end of the stick, and Black women, because women have ourselves, in general, experienced discrimination, but Black women, being both Black and female, have experienced very high levels of discrimination, and that's tied in to chronic stress. But we'll talk about that in a minute. But when it comes to this sort of cultural thing, therefore, it means that when something is being discussed in the medical establishment, for a lot of Black people, they think, oh no, that's not for me. That's not for me. And of course, we haven't been historically included in research.
No.
And when we have, exactly. And when we have, it has been a lot of the time negative. So we've been experimented on rather than included as partners in research. And so as a result of that, there is fear. But then there's also fear around the myth, the hormone myth. Oh, HRT causes cancer. HRT causes heart disease. There's so many different myths. Hormones are bad for you. It's unnatural. All these myths, right, complicate the picture. And then, of course, where are we getting our information from? And a lot of the information is coming from friends and family networks rather than authoritative sources, because again, mistrust, right? So that perpetuates myth in the community. And you can then understand why this sort of reduction in engagement. But then again, its access is also reduced. There's not as much of a concerted effort to reach the Black community where they are in the churches, mosques, salons, all these places. Black people are not hard to reach. Is where are you looking for them? I heard someone say, you don't look, I think it was Karen Arthur, who's just this brilliant menopause Black advocate. You don't look for crabs like if you're looking for crabs, you don't look for them on the street. You go to the beach, right? So again, we need to move away from this language of hard to reach. No, Black women are not hard to reach. Is where you're looking for them.
Yeah, that's a very, very good point. Now, you mentioned sort of the load there as well, the sort of allostatic load that comes with the discrimination and everything else that you've got. But so tell us a little bit more about that as well and how it impacts.
Allostatic load or mental load is one of my big passions. I mean, for all women, I'm aggrieved that women are still carrying a disproportionate level of mental load in 2024 as we're speaking now, because of the impact on long-term physical and mental health. Now, all women live longer, quote unquote, but actually, how much of our lives are we spending in health? Much less. And this is the issue, because allostatic load is a cost. It costs because we are doing things like being the number one caregivers, or the most likely to be caregivers. Many of us caring for 2 or even 3 generations, as well as working full time, because of this new kind of myth. Well, it's not that new, but at least 20 to 30 years where there's this push to women can have it all. Or, the question is, what is all? And secondly, what is the cost of trying to have it all? And this mental load is so heavy, but then there are other aspects of the mental load as well. So I talk about the cultural and family expectations, and this could be external expectations, like people, like in African culture, for example, there's a real big pressure to get married before you're 30. There's pressure once you're married to have that first child, and once you've had that first child, where's the second child? But then there's also a lot of pressure for you to succeed in your career. So again, as a Black woman, there's a lot of pressure on getting career success. And then, apart from those sort of familial and cultural expectations, so even in the Caribbean, there might not be as much of the pressure as there is to sort of settle down and get married as big as the pressure is in the African community. But there are other pressures, particularly with regards to defining success, right? And then there is also what I describe as historical. Well, it's not really that historical, because still in a lot of African and Caribbean communities, it's still a very patriarchal community. And so women are thought of as, not quite full citizens, and are still, thought of as they should be in their place. Like, it's changing, it's getting better. But I mean, still, to get some passports in Africa, you have to get a letter from your husband if you're a married woman. Can you imagine your passport? I discovered this recently. I was like, what is this? So,
if you're not married, can you get a passport then?
You need a letter from your father or not? Like, I think, I'm not sure if you need, I don't know if you need a letter from your father, but you need a letter from your husband. It's on the list. I don't know if they overlook it, but it's on the list. I was like, what? So again, it's very patriarchal societies, and all of what that all means. Because in the context of, like, when we start thinking about menopause, sexual dysfunction, loss of fertility, and that brings me to actually other aspects of the mental load, which is other things that we don't necessarily talk about too much, like infertility, miscarriage, divorce, domestic violence, sexual trauma, and what I call the unexpected singlehood, which really impacts. It's quite common in the Black community, which means people want to be in a relationship, but they haven't quite found the right partner. Now, because of societal constructs, and this is really an offshoot from slavery and colonialism, there's actually an issue in finding partners, particularly when Black women live in the West. And so there's this unexpected singlehood, which can really be devastating when a diagnosis of menopause, or even worse, POI, which is premature ovarian insufficiency, hits. And then also, when you're thinking about all of those things, when there's already existing socio-economic challenges, which, we have to be honest, many Black women, many in our communities face those challenges more. Now, things are changing, but it's still a big issue in the Black community. So you can see how the mental load can really be very, very heavy indeed. And then adding chronic illness. Now, Black women are far more likely to have chronic illnesses like obesity, hypertension, type 2 diabetes, autoimmune conditions. I'll say it again, autoimmune conditions. These diseases are also, particularly hypertension and chronic stress, are also tied or even unearthed by this heavy allostatic load. So there might have been a genetic predisposition to it, but then it's unearthed. And, I often share my story, being that I was diagnosed with hypertension at 27.
Wow.
27. 27. So there's been hypertension in my family, but they've all had it in their 40s. I believe it was the stress of being here, trying to do training, marriage, all of it at the same time. So a heavy mental load at the age of 27 that unearthed it. And I've also struggled with 2 different autoimmune conditions before I'm 40. So again, I'm obviously healthy and well, and that's because I have privilege of my position, right? So this is one of the things that I think impacts Black women in terms of the mental load.
Just a couple of stats on that, because I mean, it's when out of that SWAN study, and they were asking, it went through and showed a whole bunch of different stats on it, basically, it's like 16% of black people versus 6% of white women reported being in poor health. I mean, that's a pretty significant difference.
Absolutely.
Being obesity, 51% of the black women were obese, 31% of the white ones. Diabetes, 10% had diabetes, 4% of the white ones had diabetes. Metabolic syndrome, 26% of black women had metabolic syndrome compared to 18% of the white women. High blood pressure, this is a whopper, 39% of black women had high blood pressure, 16% of white women. And there are significant differences in
this is like nearly double for most of these things. And that's why we keep screaming health inequity, Black health inequity. It's not just because I'm Black, it's because the stats, like you've just read, show that Black women significant, disproportionately worse health outcomes.
Yeah, and in the end, I mean, the stats that I forgot to look up was the mortality rate difference between women and women and Black women and white women when it came to heart disease. But the dementia is, I'm still reading from this, every time I think about it, it knocks me for 6, really, is a 25% greater chance of developing dementia. And, what does that say? 25% greater chance.
It's shocking. And again, it boils down to the risk factors. It boils down to allostatic load. It boils down to healthy lifestyles. And the reason is because healthy lifestyles are a privilege. It's a privilege to get good food, not just the privilege of cost, but also a privilege of time, right? It's a privilege to be able to have time to exercise or have spaces to exercise and move. And all of these things, these costs are more difficult for Black women to pay the price for that because they're paying the price in other ways. And so you then have this, as you say, perfect storm, because when estrogen is doing this in perimenopause or is, removed from the picture postmenopausally, evidently the health outcomes start to pile up.
Yeah, absolutely. And in terms of health outcomes and those kinds of things, so we've got in this perfect storm, we've also got 20% of Black women are more likely to suffer from depression and then 13% of white women, which is an incredibly scary sort of figure in itself. And we've got all of these things going on together at one stage. So I'm a bit obsessed with the whole role of the vasomotor symptom in this at the moment. And I'm thinking that, vasomotor symptom, because the other thing that was really massively affected with Black women was sleep. You sleep less hours, you find it harder to get to sleep, you wake up more often. And as we know, sleep gives a rise in your inflammatory markers, sleep disorder breathing, all of those kinds of things. You actually had less of the restorative type of sleep as well, which is kind of bad. Not kind of bad, it is actually bad. And I always come back to, I'm thinking, how much, if you've got these goddamn vasomotor symptoms, how much of a role are they playing in this? Because they can be awful at night.
Do you know what? When people have bad vasomotor symptoms, and in particular, as you say, with Black women, they're more severe and they last longer, it can feel like a prison sentence because it interrupts sleep. So there's 2 different things with with the perimenopause and the menopause with sleep. So the vasomotor symptoms can mean night sweats, people having to get out of clothes, change, they're struggling to sleep because it's so hot. And then there's also sleep disruption that occurs. That's also a menopausal symptom. And therefore, you then sometimes have the two of them. And of course, poor sleep is an independent risk factor for lots of other health problems as well. So you now get this kind of chicken and egg situation. I'm not sleeping, so I'm tired, I'm more at risk. My vasomotor symptoms worse, or the experience of my menopausal symptoms are worse in general, which include the vasomotor symptoms. And then I'm more tired, my mental load is worse, and therefore my sleep is worse, and then it just becomes this horrible snowball experience. And often when women present, they're literally at their wits' end.
So what do you do with them then? When they turn up on the doorstep and they're going, I've had enough, what are you doing?
I think the first thing is to kind of reassure women that they're not going crazy. This is a real thing. Because for a lot of them, they're like, am I? Is it? And I think that validation of what menopause is and how bad it can be. I mean, of course, there are women who have no symptoms, joyful for them. But for those who are really suffering, validation is so important.
Especially if you think you're losing your mind.
Absolutely. Loads of them think they're about to have dementia because of the brain fog and the memory challenges, the word finding difficulties that you get with perimenopause and menopause. So again, that reassurance that what you're experiencing is common. What you're experiencing lines up with the menopause. I mean, I'm always really passionate about also making sure that we're not missing anything else. First and foremost, I'm a physician, right? So I did internal medicine before I did general practice, women's health. So I will always check for other things. And I think that's really, really important because again, Black women are at high risk of having other issues as well. Higher risks of strokes, higher risk of having cancers diagnosed later, higher risk of diabetes. We already talked about that. So all of these issues, higher risk of autoimmune conditions, which can present very similarly with vague symptoms. So again, please don't leave your clinical hat off and think, just focused on just menopause. Is really important.
Yeah, you've got to rule out everything else.
Yeah, you have to look at the woman as a whole. Then comes me, Dr. Johnson. I will always have a biopsychosocial approach, always, because they are always factors that integrate to the woman in front of you. She's not just a menopausal woman. Often she's a menopausal woman with a heavy mental load and challenging social factors. And all of those things, and then the psychology of it. We've talked about some of the cultural factors. Now, in African and Caribbean communities, depending on family structure, people may have a positive or negative approach towards aging. I always joke that my mom was already trying to be 60 when she was 55. She'd be like, I'm nearly 60. She was, because to her, age is a positive thing. In Africa, a lot of communities respect age. That's not to say that, because menopause and age are not quite the same thing. Because sometimes they respect age, but they also think that because you're an older woman, you need to stay in your lane. When it comes to sexuality and all of that. So I'm not saying, it's a complex thing. Please don't misunderstand me. But what I'm saying is that psychologically, your psychological thinking about what is happening with you, which is obviously going to be impacted by your previous experiences, what you've heard about the menopause, but also all those other things that we talked about with the mental load and the things that we might not have spoken about, like unprocessed psychological trauma. All of those things bubble up to the surface. So it's really important. And then the other thing is, again, women are really generally quite bad at self-care and self-prioritization. So one of the things that I often say to women when it comes to menopause and this psychosocial thing is your capability is largely the same, but your capacity is changing.
Yes.
Now, capacity is really important because you have to be able to honor your capacity to achieve your capability. You can't just keep piling on and piling on. And no amount of, and we're going to talk about some of the treatments, HRT or testosterone, all of those things is going to solve what is in fact a mental load over capacity issue. Does that make sense?
Yeah.
And so I always start there. Let's assess mental load. Let's assess psychosocial. And then when we've put things in place, so I often talk about, and I learned this from this incredible occupational therapist, which is elimination of things that you don't need to do. Delegation, so finding someone to help. So that could be partner, that could be community, that could sometimes be paid for if you can afford it. Although we know obviously for a lot of Black women that can be a challenge, but what we can do is build a village where we can support each other even if we can't afford help. And that for me is really important. And then of course, facilitation. Nowadays, we have so many different tools, including things like getting things auto-delivered, AI, all sorts of things that can help facilitate the process. I know it's not perfect and it's still being refined, but again, all of these things can help to reduce our mental load. But then there's also really important things like movement. Movement doesn't have to be in the gym. It could be outside. It could be in your house, watching a video, doing, videos from YouTube. But movement, it could be dancing. It could be dancing with your kids in the house, having sort of 5-10 minutes where it's dance time, movement. Everybody can do movement. You just have to tie movement to joy. And that's what I always try and recommend. So spending time in nature is incredibly restorative as an independent factor, actually. So again, I really encourage movement, eating healthily. You should have vitamin D daily, so 1,000 units of vitamin D daily. And also, if you're not getting enough calcium in your diet, and there's a calcium calculator you can use to get how much you are, then you should be taking that as well. And then it's all of those things, the lifestyle factors, they are the pillars. And I talk about also being mindful about what's coming in. So I talk about notifications from emails. I talk about social media, the 24-hour news cycle. Just cut the notifications so you're intentionally checking rather than it ruling you and doing drip, drip, drip on your brain the whole time and sucking out energy. So that's
so bad.
So for me, that's one of the beginning of the conversation. Then we go down to treatment options. And of course, the biggest one is HRT. Now, HRT, and I think this is really important because there's so many myths around HRT in the Black community. HRT is the best treatment for perimenopausal and menopausal women if you can have it. And most women can. For the vast majority of women, the benefits of HRT far outweigh the risks. I'm going to repeat that. For the vast majority of women, including Black women, the benefits of HRT far outweigh the risks. And I think this is really important to understand because what is perimenopause and menopause is losing that estrogen, or the estrogen kind of going crazy and up and down. And HRT helps to stabilize it at a level that then helps with the symptoms. Now, of course, everybody doesn't get an instant, and often it takes about 6 weeks for you to see the effect anyways. But not everyone finds it like it's amazing cure. And sometimes it has to be refined. The dose needs to be changed, the type of HRT needs to be changed, and all of that. And this is why it's important to speak to someone who knows or has some knowledge about it.
Yeah. The in terms of when you, it seems that there's a lot of myth everywhere about this. That we still hear the same things in virtually everywhere, that is going to give you cancer, it's going to do all of these sorts of horrendous things. But one of the other things that people don't really talk about is there's specific benefits, especially for things like osteoporosis, for people with POI, for everything really, for their heart and brain risk and bones. There's a lot there that I think needs to be sort of unpacked a lot more.
Absolutely. And the thing about it is Black women are far more likely to get POI. This is another thing that was brought up from that from the SWAN study. POI is premature ovarian insufficiency, which is when the ovaries stop working before the age of 40. So, and women can get this from 15, from very young ages. And often when women get it, the risk to their future health is so high. So this is not an age group in which it's a maybe, unless there is a direct reason, like a clear clinical reason why they can't have HRT. It is strongly recommended that women who have menopause before the age of 40, some will even say before the age of 45, should have HRT because of the long-term health effects on their bones, on their heart, potentially even on their brain. So we know that early menopause can increase your risk of dementia. What we haven't fully established is whether HRT will help protect against dementia in the long term. That's still being researched, but we have very good research to show that HRT protects the bones, HRT protects the heart, and Black women are far more likely to die of heart disease than they are to die of breast cancer. Now let's talk about breast cancer. That's the big one, breast cancer, and then to a minor extent blood clots. Oh, I can't have HRT because I have blood clots. Well, first and foremost, let's even let's take blood clots out of it. Yes, you can have HRT, you just have to have it via the skin. If you have a history of blood clots, or if you have a history of predisposed towards blood clots, I know a lot of Black women have autoimmune conditions. Yes, you can have HRT via the skin. There is no increased risk of blood clots.
What about sickle cell anemia?
So with sickle cell anemia, you can have HRT. You can via the skin. Again, no increased risk of blood clots. Because if you have it via the skin, it goes away from what we call the first pass metabolism, which is what triggers the clotting factors. It's only if you're taking via tablet that risk is there. It's still a small risk via tablet, but it's eliminated by taking it via the skin. Now, when it comes to breast cancer, and this is the big one, so entrenched that women can't get away from, oh, I'm really worried it's going to give me breast cancer. Firstly, the increased risk for breast cancer really is typically over the age of 50. So for women with POI, there really isn't a statistically increased risk of breast cancer. Now, if you are menopausal, postmenopausal, there is an increased risk, but it's so small. It's around 5 to 10 in 1,000 women. So we're talking about a 0.5% increase in risk. This is so tiny. Whatever your risk was before, and other things like being overweight, smoking, alcohol, all of these things, which can also impact your menopause symptoms, by the way. So it's really important that you have a healthy lifestyle, can increase your risk of breast cancer to a more increased effect. So we're talking about reducing your risk factors for breast cancer. You should be doing your monthly breast self-examination, which is checking your breasts for lumps monthly. And when you get called for your mammograms, you should be going. And in that way, you are reducing your risk. Now, I'm aware that Black women are, when they do get breast cancer, get it younger. So I'm aware of that. And that actually is tied to having a higher background genetic risk of mutations in the BRCA1 and BRCA2 genes. So Black women have a higher risk of that. So that's similar to an Ashkenazi Jewish population.
Okay.
So yeah, Black women have a higher risk of BRCA1 mutations. And so it's really important to understand that Black women are less likely to get breast cancer, but when they do get it, they're more likely to get it younger and they're more likely to die from it.
But when we come to dying from it, these days, the rate of the survival rates are very good, aren't they, generally?
Absolutely.
Yes, you're probably more likely to die of a heart attack than you are to die.
Much more likely to die of a heart attack. So, and then the other thing is the HRT is not affecting this risk. So the risk that
Oh, I've lost you. Frozen.
That higher risk of getting a genetic predisposition, you're born with that risk. You're born with it. You're born with that risk. The added risk of HRT is minimal on that. So as I said, it's 0.5%. It doesn't get bigger if your risk is already high. So a lot of the time, if you do get breast cancer whilst on HRT, you're already going to get breast cancer. So at the end of the day, it's not necessarily it's a very small risk. And when we think about the benefits, like from heart disease, which is a much bigger killer, you are far more likely to survive breast cancer. Because even when we say the risk of Black women dying from breast cancer is higher, you still have an 85% chance of surviving breast cancer. Now, when we compare that to the chances of surviving a heart attack, then that's lower.
Yeah. If in terms of things like that, when we say, well, I've got the BRCA gene, I don't want to take HRT, but my vasomotor symptoms are hell, what other alternatives are there these days for them?
So I didn't say if you have the BRCA gene, and it's still not you can't have HRT.
No, just in case if this is in there, if they come in and say, you know what, I hear what you're saying, not interested, not going down that route, don't want to take it, what are my options?
So there's a brand new drug called fezolinetant, and actually, it's an NK1 inhibitor. There's actually a new one coming up because when I went for the American Menopause Society conference. I did in September, and while I was there, I realized that the new one coming out, which is an NK1 and NK3, which they think, and in the preliminary study, it's not out yet, but they think it will also help with vasomotor symptoms and mood, possibly.
Ooh.
Watch this space. So fezolinetant has been a game changer in terms of giving us an option for vasomotor symptoms that doesn't have all the quite difficult side effects of some of the other things. The difficulty is that it's not readily available in the NHS. So it's more something that you can get in the private sector. We hope that it will become more available on the NHS soon. But if you just a quick run through of some of the other alternatives. So medications like that have been historically used for depression and anxiety. So things like venlafaxine, which is an SNRI, and other SSRIs like fluoxetine or sertraline or citalopram can be used to help with vasomotor symptoms or mood symptoms associated with menopause. Now, venlafaxine is probably the most effective in that category, but there's also things like clonidine, which is an old blood pressure medication. Sometimes if you've got high blood pressure, you're able to stomach the side effects, it can be worth a try. There's also drugs like oxybutynin if you can stomach the dry mouth, but if you have urinary symptoms, it can be a good factor as well, because obviously we know that with menopause, you get the genitourinary syndrome of the menopause. And for some women, urinary frequency and incontinence can be a problem. So oxybutynin can be an option. Then you've got your sort of gabapentins and pregabalins, which you can use. Again, those drugs can have really not very nice side effects and can be addictive. So we are careful with them, but it's an option, particularly if you have joint aches and pains, which again is a common symptom of the menopause. So the thing is, there are options.
There are. Just let me take you back to the SSRIs and the antidepressants for a second, because people often get very offended when people say, well, I can give you an antidepressant, but I'm not depressed. But then it's not used for that purpose, and it's at a much lower dose, isn't it? And it's doing a different thing.
So yes, so it's helping with the vasomotor symptoms, but it's also helping because often we have mood dysregulation. Now, I'll say again, for mood dysregulation in menopause, your best treatment is still HRT. But for women who can't have HRT for whatever reason, then this is an option. And it's not like we're using it for depression. It's for the hormone-related depression or anxiety, plus the vasomotor symptoms. So we think it works differently in that regard, and it can be a helpful option. But then, of course, depression and anxiety can coexist or predate menopausal symptoms. So we still have women who are on an SSRI or an SNRI and on HRT as well, and that's a combination that can also work.
Yeah, yep, absolutely. Other things, there's one in the book that you've got there. You have a point there where it says change your perspective, and I love this. But can you explain what you mean and why?
So for me, perspective is so important. And this is, I've talked a little bit about my health history. So for me, I'm talking about this not just from a clinical perspective, but also from a personal experience. Plus, I have done a little bit of basic training in CBT for menopausal symptoms. And this has really empowered my practice because I'm very much about a holistic approach, as I say, biopsychosocial. Now, when we were having this training, they gave two examples of one woman who was supposed to be going out for, a party. And she gets there and she starts having a hot flush, and immediately she's thinking, oh, everyone's noticing, I feel really uncomfortable, oh God, I have to leave. And she cuts her enjoyment short and she goes home. Now there's another woman who has exactly the same, and she's thinking, oh, it's happened again. Okay, just breathe through it. I'm not going to let this stop me. I'm not going to let menopause stop me from having a good night out. Breathe through it, gets out her fan, has a bit of a joke about it, and gets on, it passes, and she gets on with her night, and she has a good time. So so I'm not making a judgment, right? Because we're all different. But the idea is that how we view something impacts our experience of it.
Yeah.
Right. And so if we have a positive perspective, menopause is not something to be dreaded or feared. Right? It's something that is a natural change in a woman's life. And so if we think about it as something that can be celebrated, something that can even open up new doors, new opportunities. Like, oh, and you know what? I don't have to worry about getting pregnant anymore. How Stella got her groove back, right? I don't know if you've seen that movie with Angela Bassett. So at the end of the day, sis, you can get your groove back rather than thinking of this as a prison or as, oh no, I'm now old. You can have a positive attitude, and that can actually impact how you experience your symptoms, but also how you experience menopause as a whole.
Yeah, absolutely. Yeah, CBT is another one of these. You remember in the first draft of the NICE guidelines, people were very upset at the way CBT was presented, and now it's sort of slightly differently presented to be considered alongside. But I actually think that CBT should be taught in schools. I know I've said this 1,000 times before. It's a resilience technique in many ways. It's just such a fantastic way of just actually looking at things and questioning your thought and thinking to yourself, did I get the right end of the stick on this? But even watching the news the other night when they said, NICE has rolled back on a CBT thing like that, and the introduction to it was of the psychotherapy, and it's like, this is not telling women that this is something in their heads. It's just giving you a tool to be able to reevaluate the way you look at
That's right. Thoughts, feelings, behaviors. And that's what CBT is all about. How you think about something affects how you feel about something, which impacts how you behave about something. Now, I've personally had quite a bit of CBT over the years. So I am a believer in this technique. And as I say, because I have actually experienced chronic health problems, it's been so crucial for me to be able to have a positive spin and to be able to, so I cannot recommend it enough. Now, the thing is, you don't have to go to a CBT session to pick up some of the principles. You can pick it up from self-help books, podcasts, all sorts of different things where you can read about how you can have a positive attitude from, it's more like a perspective shift. I'm not saying that it's going to wish away really bad hot flushes. No. And I'm not even saying that, again, I repeat, HRT is the best treatment for menopausal symptoms. And if you can't have it, there are other options. But what I'm saying is an adjunctive plan to use psychological beneficial methods with your symptoms can be really, really impactful.
True, and you can use it across. I mean, I've done it for anxiety, so I mean, you can use it for so many different areas that you could apply to your everyday life. Really,
that's right. I mean, libido, insomnia, CBT can be vasomotor symptoms. CBT can be adapted to so many different aspects of menopausal symptoms and issues.
Yeah. So we've mentioned, all right, so you've mentioned the staying active, managing your mental load, not smoking, eating well if you can, your vitamin D. One thing we haven't mentioned there is you're in your book, you also talk about the importance of your pelvic floor.
Absolutely. I feel like we haven't talked too much about GSM, and this is genitourinary syndrome of the menopause affects up to 50% of perimenopausal and menopausal women. You may ask what this is. This is the vaginal dryness. This is the urinary frequency, increased frequency of urinary tract infections. This is even including a urinary incontinence. And this is all to do with reduced estrogen to the vaginal walls. And now, if you've already got a weak pelvic floor, and that can be worsened by having carried a baby or having delivered a baby, then that can make things worse. So pelvic floor exercises are not a nice to have. They're a fundamental part of treatment in addition to vaginal estrogen. And most women can have vaginal estrogen. Even if you can't have systemic HRT, most women can still have vaginal estrogen. There are very few who can't. And at the end of the day, all of that in combination can help. And then lubricants for intercourse, if intercourse is painful, for dryness. I also talk about not washing with soap. Please don't do that, sis. Please don't put stuff in your vagina. Just let vagina is self-cleansing. You can use an emollient to clean the vulva. And I always mention this because Black people are more prone to dry skin. We would never have a shower and just be like, yeah, we're going out without putting moisturizer on. And that's because our skin gets drier. So it's the same with our vulval skin, which is why I recommend an emollient, which is kind of like an eczema cream that doesn't have any coloring or doesn't have any perfume, that you can use to moisturize the vulval skin, and then use lubricant. And we often talk about this slip and glide, where you can mix water-based lubricant with an oil-based, and then you can get a really nice enhanced sexual experience and reduce the friction for the vaginal dryness.
Condoms okay with that if it's an oil-based?
So condoms not okay with oil-based. Condoms, you can use a silicone-based or a water-based, but condoms not okay with oil-based. But if you're not using a condom, then you can use the slip and glide. Thanks for pointing that out.
I love the slip and glide. I think that's great.
Absolutely, a big fan.
Yeah. To find good products though is it's really very, very difficult. I've been looking at developing a vaginal moisturizer for quite some time, and have a little prototype here. And as an analysis, I went through the top 20 brands and their ingredients list, and there were more than 200 ingredients in those 20 brands. And you're thinking, why are these things even here? They're just things that you would not want anywhere near the skin on the outside of your body, let alone your labia and your vagina. It's kind of scary stuff out there. It's very hard to find things that are the right pH, the right osmolality, and don't have nasty ingredients in them.
That's right. It can be really tricky. I mean, sometimes I recommend Yes. I don't know if you've heard of it, the Yes vaginal moisturizer. For me, that's one that I think is okay, that can work well with vaginal skin. And they do have a water-based and an oil-based, but it's quite expensive. So I sometimes say just you can get the water-based and then just add in some natural coconut oil that doesn't have any perfumes and stuff like that, to try for the slip and glide. But yeah, you're right. It's like quite a lot of the other ones on the market. There's some
really important because this. I didn't tell you this when I met you the other day, but this was my worst symptom. I got to the point where literally I could barely sit, I could hardly walk. Every time, there's nowhere in the world exercising was hell. I could hardly walk without having to stop. Like if we take the dog for the walk around a park somewhere, I'd be ducking up behind a tree every so often and rearranging my labia because it was so painful. So it was horrible. So this is one of the things that is close to my heart when it comes to that, is getting these things sorted. And vaginal estrogen made a huge amount of difference. And the e-string and the estradiol cream for me have been just thank you God.
Thank you for sharing. I am a big believer.
There's nothing I won't talk about.
I'm a big believer in e-string because, like, literally, this is the vaginal estrogen ring that you can put, and you can use it as an adjunct. So you can use the cream with the e-string to provide more treatment for some women who have severe symptoms, or you can use it on its own, because for some women using the cream or the pessary doesn't quite work. And the thing about the e-string, because with the cream and the pessary, you often then get down to 2 or 3 times a week, which for some women is not enough, right? Yeah. And they just need that continuous. And so with the e-string, you get that, which is such a great tool. So yeah, these symptoms, we don't try and talk about them, but especially in African and Caribbean relationships, where these things can become a big issue if women are not able to have intercourse because it's so painful, and they're struggling to talk about it with their partners. They don't even know how to mention it to clinicians. And therefore, as clinicians, are we asking this question? Because, as I say, it's going to affect up to 50%. And you just shared your experience.
It took me more than 2 years to you sit there and you're looking at yourself and you're going, oh my God, it's come to this. Everything's gone south. I'm overweight. I can't even have sex. Your partner's looking at you thinking, you don't love me anymore or whatever. It really does affect your relationship. It takes it took me a couple of years to actually get to the point to say, what, actually, it's not you, it is me. And there's a lot of, coming to terms with who you are as a woman now. It's a difficult phase to go through.
Absolutely. I mean, I'll share my own brief experience. Postpartum, I got really bad vaginal dryness. The thing about it is, I'm a doctor. I should have known. I'm a women's health doctor. Like, I should have known that it can be. I mean, obviously, I had a vague understanding, but I didn't realize it can be that bad. Like, so even till now, I have to use an emollient, and I've had to, like, even till now, I can't get away with, like, not using my emollient daily. But it was like, literally, I had to use lubricants. I had to use all this stuff that we're talking about. So again, I was like, oh, a hint of what is to come.
Yeah, but a lot of people don't join those dots either. You sort of, yeah. And it's one of those things, you think you actually tell pregnant women, if you've gone through this, make sure when you hit perimenopause that you're aware that this could happen again, because that's why it happened this time.
That's right. And this is the thing, is to know that there's treatment. I know, like you said, it took 2 years, but you got better. And this is the thing for women to have that hope, right? Because we know that the vast majority of menopausal symptoms, including the vasomotor symptoms, the mood symptoms, all the other symptoms, the physical symptoms, the joint aches and pains, most of them will get better. The ones caused by menopause, by the way, because obviously there's some symptoms like joint aches and pains that might be osteoarthritis and other things. But the ones caused by menopause, most of them will get better in time. So if you take HRT, that will help with the transition. But even if you don't, most of them will get better in time. But you know what never gets better? Genitourinary syndrome of the menopause. Yeah. That, in fact, gets worse with time. And this is why when we prescribe vaginal estrogen, it's a long-term treatment. It's not a course of treatment. Because if you stop taking it, the atrophy will come back, the discomfort and the pain will come back. And so this is also why this symptom needs to be treated.
Yeah, absolutely. Not to mention the UTIs.
That's right.
Yes, which was sadly omitted from the new NICE guidelines. But anyway, there you go. Is there anything else that you think that is important that we haven't covered?
Let me have a look. So I think
Oh,
involvement.
I know it. I know it. The other thing that I was going to ask you, sorry to cut you off there, was that they said once you have actually gone to see you, or once I work up the courage and I think, okay, I've got to come and see you. What are the checks that you would advise women to be asking for when they do come to the doctor, apart from keeping up to date with your screening?
So I think because of the higher risk that Black women have with hypertension, so 50% of Black adults over the age of 40 will be hypertensive, higher risk of diabetes. So we have double the risk of diabetes for Black people compared to white people, slightly lower than Southeast Asian, but still a very high risk. I think those sort of basic tests, so blood pressure, diabetes, cholesterol, the heart disease risk tests should be done. But so that's thinking about your cardiovascular health. Now, for your longer term health, I think the cancer screenings are vital. So we've got cervical screening, which is really important. You should have this up until the age of 65. If it's difficult because it's painful, you can get your vaginal estrogen, your lubricants, and then there are different sizes of speculum, right? For my postmenopausal women, sometimes I use a small or even an extra small if they're unable to tolerate a bigger size. And so you can ask for that. Rather than not having the smear, you can say, can I have a virgin speculum or an extra small speculum? Now, there's also breast tests, so the mammogram, which they normally in the UK offer from the age of 50. Now, watch this space because there's a whole lot of research ongoing with breast cancer screening, having to do with density and all sorts of things. So in the next 5 to 10 years, guidelines may change. So do watch this space. But for now, go for your mammograms when you're called. And then, of course, there's the bowel screening, which is really important. When you get called for that, please do it. And this is because bowel cancer is often symptomless. And so this is why there's a screening program for it. But this is also something that's really important.
Yeah, there are two questions for you over here. I'll do them in reverse order. What is good for heart disease scan? You mentioned CT, angiogram, cardiac PET scan. What are we talking for heart screening then?
So, I work between the NHS and the private sector, and so this is a very. I think that it should be based on your risk factor test. We have what is a fairly good risk calculator, which is very cheaply done. You just need a blood pressure and a weight, a height, and a cholesterol result. And that can calculate something called a Q risk 3, which gives a 10-year risk score, which is quite well validated. And there's even a space for Q risk 3 includes ethnicity, so it's factored in, and that can give a really good 10-year risk score of your heart disease risk. Now, I don't know how much of menopause has been put in there, so perhaps Q risk 4 or 5 will add that in. But for what we have now, it's cheaply done. Most GPs are able to do that. If your risk score is over 10%, then we need to be working very, very hard to minimize your risk profile. But I think if it's under 10%, but higher than your age, so there is an age, what is expected for your age. So if say, for example, it's under 10%, but it's double what would be expected for your age. Similarly, I would be expecting, for us to be really working on the risk factors. So that's lifestyle stuff. So weight, movement, smoking, alcohol, your diet, all of those sorts of things. In addition, you may need, if you've got high blood pressure medication or a statin. Now, when it comes to heart scans, now on the NHS, that's typically only done as for secondary prevention, or if you have risk factors for things, or you have symptoms of things like angina. Most of the time, you have to have a symptom before you're referred to the cardiologist and tests are done, which can include a CT coronary. In the private sector, you can have a screening CT coronary. Now, I think you have to be counseled as to whether this is something that's appropriate or not, because it's not a perfect test, one. Two, it can pick up things that you weren't intending to find, and that can send you down like a rabbit race. So I think if your risk level is normal from a Q risk score, your blood pressure is well controlled, your cholesterol's good, I don't think you need to be thinking about a CT coronary. However, if, say, for example, you've got a family history of, and a family history is really important as well. Sorry, I forgot to add that. But say, for example, if you've got a family history of someone in your family who, especially a woman with heart disease under the age of 70, a man with heart disease under the age of 60, and you have, maybe very high blood pressure, bad cholesterol, you have risk factors. If you wanted to go down the private sector, it's worth having a conversation to see whether a screening CT coronary is appropriate for you. But you have to have no symptoms. If you have symptoms, then you need to be seeing a cardiologist.
That makes sense. The other question was about vaginal Utrogestin and how useful that is for perimenopausal symptoms, given that's a sort of an off-license way of using it, but it seems to be as effective.
So on the continent, vaginal Utrogestin is used, and so even though it's off license, you can use it interchangeably to oral, if that's preferred, if that's the preferred method of use. So it is off license, and you have to be aware of that. But on the continent, it is used in that way. So I'm talking about Europe. So, but this is as an adjunct, the progesterone part of now I know that in some countries they're doing weird and wonderful things by starting women on just progesterone for perimenopausal symptoms. That's not something that the BMS guidelines have any scope for at the moment, and so that's not something that I do in practice. So generally speaking, when we give progesterone for HRT, it's as part of estrogen and progesterone. Now, if a woman doesn't have a womb or any endometrial tissue, so like she doesn't have endometriosis or any other sort of lurking stumps or anything, then she can have estrogen alone.
Good hope. There is one last question here, which I will ask because we are out of time, but I'll ask it anyway. Mammogram versus MRI of the breast. If you're concerned about radiation, is an MRI sufficient?
This is what is being researched. So you know how I told you all change, please? Right. So we know that MRIs of the breast giving there is some evidence to suggest that it might be better, particularly for women who have dense breasts. And this density of breasts is more common in younger women, but also there's something that it might be more common in Black women. And so then again, mammograms in those dense breasts are not really that great in screening. So but MRIs are expensive. They are expensive. The radiation in a mammogram is not something that I would be really that concerned about. It's nowhere near as much as in a CT, for example. So yes, it's some, but it's not, having a mammogram every 3 years, the radiation levels are not significantly concerning. But of course, your history of radiation does matter. If you've had loads of CT scans early in life, and some people are just unlucky. So if that's what you're worried, I as a clinician wouldn't be overwhelmingly worried about the radiation risk from a mammogram. But what I could be worried about is whether the mammogram is the most appropriate test in a woman with dense breasts. But at the moment, on the NHS, that's what we've got. And then of course, if there's an abnormality, they can send you for ultrasounds and more investigations, and that does happen. In the private sector, of course, there's lots of different options, but for many, a mammogram is still the first step. But you can of course choose to go down the pathway of an MRI or even an ultrasound. But again, a screening ultrasound, a breast ultrasound, is not necessarily also that validated. So it's not particularly better. But an MRI, yes, it can be. But again, it's got to be in the right way. And we just don't have as much evidence, and that's what they're trying to collect. So there's studies going on now. So whilst I was in America at the American Menopause Society, there was a session just on this. With all the research that's going on. And it's so important that we as Black women join in the research.
Yeah, absolutely. Brilliant. All right. Final last word. What's your take-home message for Black women in menopause then?
I think the important thing is the perspective matters, right? And really, I know that it can be hard to have these symptoms on top of what can already be a lot of challenge, but there is help. There is treatment, and there's community. And that's so, so important. So, get stuck in, don't think you have to go through this alone. And there's always going to be an answer to help you at this time.
Brilliant. Thank you for that. Now, if people want to find you, where do they find you?
So I'm available on @Dr. Showcare. So that's on Instagram, that's on Twitter, also on YouTube. And my website is www.drshowcares.com. So that's DRSHOCARES.com.
Brilliant. Thank you for that. A number of people here on the Instagram going, thank you so much for that. They thought that was really interesting. Even a white woman there saying great advice and very helpful for her as well. So there you go. Being inclusive. So I will end this here on that one, and now, and I will end this over here and say thank you very, very much again, and hopefully we will speak again soon.
Yes, I just want to say about the book, which can be downloaded from my website for free, or we're going to put it on the MREF anyway. Hopefully, we'll see.
Yep. Yep, we will. Yeah, little booklet. It'll be there as a resource. Excellent. Thank you so much, and we'll speak soon.
Thank you.
Bye.